include treatment of infections in immunocompromised hosts and antimicrobial pharmacokinetic/pharmacodynamic optimization.
All right, everyone, let's give a warm welcome to Dr. Rose.
Thank you very much. All righty, welcome everyone. Thank you for joining this session. So we're going to be doing a guideline review for the recent updates to the complicated urinary tract infection guidelines from IDSA. I really liked how Erin started her last session, so I'm going to try to do something a little similar just to get an idea for the room. So how many focus are on the inpatient side of things? All right, a good chunk. Outpatient, one. And then long-term care or anyone else that I'm missing? One over there. Okay, that works for me because a lot of this is going to be spun from the inpatient side of things, which is where I focus most of my work. As disclosure, I've served previously as a consultant for Shinogi. Learning objectives for today. So we're going to be going through these updated guidelines, and it's a 5-piece guideline that we'll talk about. I'm going to focus on 4 of the main parts of it that are really revolving around antibiotic selection, both empirically and definitively for patients. Then we're going to transition and talk a little bit about different diagnostic stewardship techniques, in addition to some antimicrobial stewardship techniques to improve care in these patients. So we, of course, need to start very globally and think about what is, with urinary tract infections, how much of a problem are these? And so these are very significant healthcare burdens. And so it's one of the most prevalent infections that's managed on the inpatient and outpatient side. And when we think about number of cases annually, 404.6 million cases in 2021 globally. So a very, very big problem, which is why, it's important to understand how we are effectively treating these patients. Zooming in specifically on the US, so this is data from 2018. Of 35.5 million hospitalizations, 2.8 million had UTI diagnosis associated with it. And of those, over 600,000 of them met the definition for complicated urinary tract infections, which is a slightly different definition historically compared to what we'll talk about today. Some further statistics. So 9.1% of all healthcare-associated infections are urinary tract infections. And when we look on the inpatient side of it, 62% of these healthcare-associated UTIs are related to indwelling urinary catheters. So that's going to be an important theme, is really adequate source control for patients. And then this last point I really like to highlight, and it'll come again when we talk about some of the data for duration of therapy, is 48% of gram-negative bacteremias are attributed to urinary tract infections. And so when we look at some of that data, it's not specifically a complicated UTI study, but a majority of those patients are falling into this bucket. So I think there's a lot of longstanding challenges with UTIs, and this is really reflected in any disease state, but UTIs in particular, it's not a one-size-fits-all approach, and there's a wide spectrum of disease that falls within this. And there's different risk stratification that goes into patients with UTI. And so, of course, we're going to have anatomically cystitis versus pyelonephritis. We're going to have patients with urinary catheters, structure abnormalities, immunocompromised. That's my bread and butter right there. And so, again, one size fits all, not really. And so what these updated guidelines in part try to do is, change some of the verbiage to not have one giant catch-all bucket for everyone's complicated if you don't meet this very limited criteria for uncomplicated. But again, even with these updated definitions, I think there's this caveat that there's still nuance within there. So we're going to start here with an active learning question. And so based on the 2025 IDSA complicated UTI guidelines, what criteria classifies a UTI as complicated? Is it A, infection confined to the bladder? B, dysuria and suprapubic discomfort? Is it C, presence of comorbidities, in this case diabetes, or is it D, fever? I'll look for a show of hands for A, B, C, couple hands for C, D, more hands for D. All right, we'll talk about it, and maybe there's some shifting in those definitions over time. So we go back to 2010, and this is where we were. And so with these 2010 IDSA guidelines, these were really uncomplicated UTI guidelines. And so their main definition that they're using is for an uncomplicated UTI, it's acute cystitis, an afebrile non-pregnant premenopausal woman without diabetes or urologic abnormalities. So a very defined group. They also further define acute pyelonephritis as that same population with an acute kidney infection. If you don't meet that criteria, you are now complicated. And so unfortunately for me, I'm complicated now. But anyone with any other comorbidities are going to be complicated. When we look at our inpatient populations, what percentage of patients do you think are uncomplicated versus complicated based on these definitions? Is it a lot of them are complicated or not many? A lot. And so this really isn't reflective, at least on the inpatient side of it, of the population that we're currently treating. So that's a challenge. So now we look where we are now with these updated 2025 IDSA guidelines. And so they now define uncomplicated UTI really from more of an anatomical standpoint. So infections confined to the bladder in afebrile women or men. And then they're specifically defining complicated UTIs as still somewhat everyone else, but it's pyelonephritis, patients that are febrile or bacteremic, catheter-associated UTIs, and prostatitis. Even within this, there's still nuance in terms of treatment recommendations for those patients, but a little bit better distinction. And this is in line also somewhat with wiki guidelines, where they really are taking more of that anatomical approach of call it what it is. We don't need these definitions of complicated or uncomplicated. Is it cystitis? Is it pyelonephritis? And use that as your diagnosis. So the first chunk of the guideline is really focused on empiric therapy after we move past the definitions, which we now have established. And so for empiric therapy, they break it down into 4 key steps. 1, how sick is your patient? 2, do they have risk factors for resistance? 3, what are the patient-specific considerations that might impact our antibiotic therapy? And 4, consider the antibiogram with a little asterisk there, which we'll talk about. So for severity of illness, they break it down in terms of patients with sepsis versus without. When it comes to patients with sepsis, with or without shock, they're recommending 3rd or 4th gen cephalosporins, carbapenems, piperacillin, tazobactam, or fluoroquinolone. If presenting without sepsis, if you're still choosing IV route of therapy, ditch the carbapenems, and if you're going the oral route, you can consider fluoroquinolones or sulfoxazole trimethoprim. What they emphasize here, and this is a direct quote, is recommendation places a higher value on providing early appropriate empiric antibiotic therapy to prevent mortality while deferring stewardship considerations to definitive therapy. I don't love that. I'm sure a lot of people in here don't love that either. But that said, I still think these recommendations in large part are in line with what we're typically thinking for patients that are admitted or coming through the ED, and thinking about using something like a 3rd gen cephalosporin potentially. So then they break it down with risk factors for resistance. So conditional recommendation, good to point that out, not a lot of great quality evidence here. But they are making the blanket statement of avoiding antibiotics to which patient has previously grown a resistant pathogen. Seems reasonable enough. I think there's still caveats within that. I think considering most recent culture results is an important part of that. So if they grew an ESBL right on that 6-month mark, but they've more recently had same organism, but very susceptible and friendly, I think it's reasonable to treat it as such. Again, still have to take into account that severity of illness within that assessment. They also make a blanket recommendation for avoiding fluoroquinolones if they've previously been used within the past 12 months. So again, a lot of the things I think we're routinely doing from the stewardship side of things and helping determine empiric therapy, now just within this guideline. So number 3, all of our best practice considerations, and again, things that should be going into routine antibiotic selection all the time. And so what types of allergies do the patient have? Does that mean we can't use our preferred first-line therapies like ceftriaxone, for instance? Do they have other contraindications? Do they have drug interactions that prevent us from using certain antibiotics? Again, pretty standard here. I don't think this is really a divine revelation for anyone in terms of how to approach empiric therapy for patients. So lastly is this comment on antibiogram consideration, or rather not. And so again, very low certainty of evidence recommendation here, but they comment on in patients with sepsis, go ahead and use your antibiogram, but that's assuming that your antibiogram is local, recent, and relevant to the patient. And so I think that's a real challenge depending on what site you are practicing in. So from my experience, for instance, at Loyola, we do a good job of annually reviewing our antibiogram. I always struggle with the relevancy piece of it. We have patients presenting from the community from all different places potentially. They're not all going to be the same. Their antibiogram could look different, but that's just the data that we don't have. So again, that's one of the issues potentially with antibiograms, which is why this conditional recommendation is placed that those patients without sepsis, no recommendation is made regarding the use of an antibiogram. One of the other challenges we've had with our antibiogram is we see pretty high rate of ceftriaxone resistance, unfortunately, within our antibiogram for things like E. coli, relevant in the context of complicated UTIs. I think depending on what types of rapid diagnostics you're doing can be helpful and kind of dissuade you from using your antibiogram. So for instance, we know it's a CTXM negative E. coli bacteremia. Our antibiogram says don't use ceftriaxone maybe, but that data is telling me we should still be able to use ceftriaxone because all of that gets lumped together. So a lot of caveats when it comes to antibiogram utilization. I'll say they're also still, from my perspective, have a role in terms of formatting guideline recommendations or institutional guideline recommendations to help providers select appropriate empiric therapy. So again, that was part 2. Part 3 is going to talk about duration of therapy. And so we're moving, towards shorter duration for patients with complicated urinary tract infections. And so 5 to 7 days if you're using a fluoroquinolone, 7 days for everything else, as opposed to treating for longer courses. So I think this is really exciting. We're continuing to see this push across the board for shorter durations in appropriate patients. This is inclusive of patients with gram-negative bacteremia. Again, I'll call out some of that specific literature later on. And the key exception here is men with suspected acute bacterial prostatitis. Again, getting that all the patients that fall in this complicated UTI bucket are still not the same, and there's still some heterogeneity there. Part number 4 of these guidelines is really focused on optimizing this IV to PO switch. And so lay out some criteria for consideration. So patients are clinically improving, they're afebrile, hemodynamically stable, and we have adequate source control, mainly thinking, do they still have an indwelling catheter, and can we remove that? Of course, goes without saying, can they take the oral medication? Also considering other enteral routes potentially if we need to. And so making sure that we have an established route to be able to give the oral antibiotic that we so dearly want to use. And then effective oral option is available that achieves adequate drug concentrations where needed. And so I think this is one of the big discussion points that I'm going to hit on a little bit later, as in more on this later. And so this discussion of beta-lactams versus fluoroquinolones and sulfamethoxyl trimethoprim, and really noting that not all oral beta-lactams are created equally. All right, that was my very quick overview of these updated guidelines and really hits the high points of some of the key things or changes within them. So now we're going to shift gears a little bit and we're going to focus more on the stewardship side of things. And so we're going to break it down in terms of some rapid diagnostic, or sorry, not rapid diagnostic, but diagnostic considerations, as well as the treatment considerations and how that all kind of plays into stewardship for these patients. So we break down with this nice little timeline and thinking about how does this treatment algorithm kind of progress. And so patient initially presents, we do our initial assessment. Really important part there is we got to get the diagnosis right. Again, I'm a pharmacist. I'm not doing the diagnosis piece of it, but that's really the essential first step. Around that time, patients are going to be subjected to some testing. So urinalysis, urine cultures, talk a little bit about maybe how good or not those are at diagnosing UTIs and whether or not they're all that helpful. And again, around that time, thinking about empiric antibiotic selection for our patients. We touched on briefly with the updated guidelines. We'll come back to it. Then eventually with our urine cultures, we're going to get some new data. So we'll get speciation of an organism potentially. We will get susceptibility reporting using those to help define our final course of therapy. That's probably the piece I will spend the least amount of time on, although it does factor in when we talk about the definitive therapy and finalization of our plans for these patients. So we're going to start here. Initial patient assessment and UA urine cultures. So symptoms make the diagnosis. I think we are all aware of the issues that are plaguing our healthcare system when it comes to asymptomatic bacteria. It's a real challenge, especially when we consider patients presenting with altered mental status, and whether or not they have benefit from antibiotics. And I think there's some clear indicators in the literature that I would say they aren't, but more on that. So treatment of ASB results in longer hospital stays, no difference in key clinical outcomes. And so really a point of emphasis of if they don't have the urinary symptoms, we should not be treating them with antibiotics or really caring about that urine culture result. Again, the reminder that no one needs, hopefully within here, is that altered mental status plus bacteria does not equal urinary tract infection. And so we are missing really the key piece here, which is symptoms. And we know in the literature that antibiotics for ASB in this older delirious patient population, they're not helpful, and in fact, they're potentially harmful. So we think about all the collateral effects from antibiotic utilization. We're talking C. diff infection. We're talking about all the adverse effects potentially associated with fluoroquinolones if that's your drug of choice that you're using. So a lot of issues that can come from antibiotic exposure in this population, not to mention the antimicrobial resistance piece of it. And so, of course, every course of antibiotics could potentially contribute to further antimicrobial resistance. The more we can mitigate that, the better for all. So looking at these tools a little bit more. So again, these are important tools. We use them. Everyone does on a routine basis for these patients, but there's some important limitations associated with them. From a urinalysis perspective, the parameters consistently have shown low predictive values. And so I'll show that on the next slide of what that looks like. But, positive white cells within a urinalysis does not mean your patient has a UTI. And I think that's a really important principle that we as the stewards tend to grasp really well. I don't know if that's always translated well to other clinicians that we are working with or trying to make recommendations to. Additionally, some of the lab values that we're looking at on a urinalysis, they're going to have different thresholds for interpretation depending on the population. Patients with indwelling catheters, of course, they're going to have some white cells. Plenty of irritation going on there. And so that's going to be different from your perimenopausal young female patient that has white cells in their urine. So not only the UA piece of it are there limitations there, but on the urine culture side of things, highly subject to contamination. I think this is always a point of emphasis, is ensuring that we are getting appropriate collection of urine cultures. And I'm realizing that my references aren't showing on here. I think they must be a little bit lower than what you can see, but as high as 42% of all cultures are contaminated. And so making sure that we're getting appropriate samples is a really important piece of this to be able to use this data to improve patient care. So looking at this figure, which I stole, I believe this is from the Wiki guideline, but they highlight, I'll use the white count of greater than 5 cells per microliter. And so you can see the positive predictive value, 56 to 59%, not too great when a lot of people will point at that and say UTI. On the flip side, negative predictive value is higher. And so that's maybe more the utility of these, is to say, we're pretty confident this patient, based on these findings, assuming that they're not neutropenic, we're pretty confident that they don't have a UTI based on this. But again, you can have a negative UA and still have the correct symptoms. There's likely additional workup that's going to go into that and potentially structural abnormalities contributing. But again, really the positive predictive value is the thing I want to highlight here of not super useful. So we know there's limitations with the testing that we do for urinary tract infections. So the question is, now what? And so a couple of things here of what those potential next steps could look like. So we revise how the tests are ordered. This has been touched on a little bit earlier in some of the other sessions. So thinking about things like computerized provider order entry and how we can optimize or guide providers to ordering antibiotics correctly or more in line with our institutional guidelines. We can use microbiology nudge comments on positive cultures. And so patient, we miss them getting a urine culture order in the first place, even though they have symptoms. What can we do to potentially still guide those providers towards maybe de-escalating or stopping antibiotics? And then the last piece of it, this is harder to implement on a local level, but we'll talk about Michigan's public health efforts in terms of benchmarking across institutions specifically for urinary tract infections and asymptomatic bacteria. So revised test ordering. This is one example of published data. This is coming out of a health system in Texas. And so they revised their order panel for UA and urine cultures. So all of it is in one essential catalog of what do you want and why. And so if you want a UA with a reflex to urine culture, which is another part of this intervention, was they've made that reflexive aspect to it. But if you want that, it requires a specific indication. And so the indications that they use are listed there. And so with this simple intervention of saying, you have to tell me why you want this, they saw 40.4 reduction in urine cultures performed, and they also saw a reduction in antibiotic days of therapy. And so again, urine cultures, I think, are a very difficult intervention to make on the fly. And so we have to have other tools in place to guide our providers when we're not always there watching them. Microbiology nudge comments. This is one that we've implemented some variations of this, where if you have a urine culture that's less than 100,000 CFU per ml of a specific organism. This study was Madeline Belk, another ID pharmacist that had published this, I believe Alabama. But assessing for urinary tract infection symptoms, urine culture is growing less than 100K. CFU per ml, antibiotic treatment is not recommended in patients with ASB outside of pregnancy and urologic procedures. Again, pretty simple intervention to say, hey, take a look at this patient again. Their culture seemingly isn't maybe microbiologically significant. There's something there, but does it truly warrant treatment? And so this is supposed to be a stopgap for the provider when they're reviewing those culture results to say, oh, maybe we don't actually need antibiotics. Maybe this patient wasn't actually symptomatic in the first place, and so maybe we can stop antibiotics. And they were able to show within this intervention that there was a reduction in antibiotics continued after 48 hours, after 72 hours, antibiotics prescribed at discharge, and total antibiotic days. So all of these were clinically significant or statistically significant from the pre and post intervention groups. And the last one, again, touching on was the benchmarking piece of it. So this is the Michigan Hospital Medicine Safety Consortium. So they have hospitals all across the state of Michigan, and very cool program essentially that they have in place. And so they have nurses that are hired by the individual hospitals, but they are trained by this consortium. And what they do is they are doing essentially like audit type data and contributing to a statewide database. And in this case, it was specifically for UTI management. And so 3-year prospective study where they were benchmarking these key UTI metrics. What they were able to look at was overall asymptomatic bacteremia related antibiotic use, and they saw this significant reduction, 29.1% down to 17.1%. To couple with that, positive urine cultures in patients diagnosed with ASB also went down. And so they're able to show a reduction in the urine cultures being ordered for patients that don't have symptoms. And then they also were able to highlight, again, overall decrease in antibiotics used for ASB. And so I think that comparison amongst peers is a really important piece of this. Hard for us to implement without, more structure at a state level for this specific type of intervention. And so things to consider potentially for an individual site is doing some random sampling of your urine culture data and seeing, are we regularly treating ASB? Because that's not otherwise really great piece of data that's easily obtainable otherwise from your medical records, similar to like things like days of therapy. And so this is not something that we have had much success with in doing some random sampling, but remains a important focus for our institution. All right, so that was diagnostic stewardship considerations. And check on time, looks like we're doing good. So now we're going to shift gears and look at the antimicrobial stewardship piece of it and think about how can we optimize empiric antibiotic selection as well as then definitive therapy. And really we'll spend the most time there on the definitive therapy piece, coming back to those core ideas of the IV to PO switch and considering what oral antibiotics we can be considering, and then the duration piece of it as well. So empiric antibiotic selections, again, going back to earlier, we hit the four kind of tenets of these new updated complicated UTI guidelines, where we're focused on severity of illness, resistance, risk factors, patient-specific considerations, and then antibiogram, maybe, maybe not. So how does this translate to the individual site? Well, I feel like what we're most familiar with, and a lot of sites produce their own local institutional guidelines. They're taking those pieces of information and saying, okay, how can we make this more digestible for the everyday clinician, and that they can say, okay, my patient should get ceftriaxone because of XYZ, done. So that's one approach. Otherwise, take it a step further. It's taking those same recommendations and building it into the EMR. So that on order entry, patients are guided to the appropriate therapy that we would recommend from an institutional approach. So this was another trial, or this collaborative was mentioned earlier during the AI talk, but we can lead a horse to water, can we make it drink? And so we can have all this, really robust institutional guidelines that say, this is a specific patient that we're targeting, this is the appropriate antibiotic for them without any risk factors. Can we get the providers to always do that? And that's not always the case. So this is the INSPIRE randomized clinical trial. This is specifically looking at community-acquired pneumonia. And what they were comparing was a routine antimicrobial stewardship efforts that all of us are doing on a daily basis versus the same, plus this CPOE or computerized provider order entry stewardship bundle. And so what that kind of looks like is algorithm of determining what's the patient's risk factors for certain MDR organisms. Would they benefit from broader therapy? If you were here for Aaron's talk, probably not. Helping guide providers within the medical record to say, this is appropriate, this is not, and this is what you should be treating this patient with. And so, again, those prompts were there, and they saw a significant reduction in terms of empiric extended spectrum days of therapy, so 28.4% reduction. So pretty massive. And then, is this translatable to other disease states? I definitely think so. I think urinary tract infections with a more algorithmic approach is certainly something that could be on the horizon. Other things that they saw more on the safety side of things are these mean days to ICU transfer. That was no different. And hospital length of stay was no different. And so, even with saying standard therapy or not this super broad spectrum, these patients are still not getting escalated to the ICU, and they're not staying in the hospital any longer. So then we're going to transition again towards definitive therapy. And so just in general, thinking about definitive therapy, we're thinking about de-escalating based on pathogen susceptibility data, of course. And why do we do this? I think we all recognize this, but just to point this out more plainly, we're trying to minimize the spectrum of activity while maintaining efficacy. With that, we're trying to reduce collateral damage, so C. diff infection being the prime target there. And then we're also trying to avoid the selection of multi-drug resistant organisms. So a lot of good reasons why we should be trying to de-escalate, or I think optimize is the better word. And so it's a two-parter though. When we talk about optimizing, we're trying to optimize the drug. We're also trying to optimize the duration of therapy. And so ways to optimize the drug, again, spectrum activity kind of goes without saying. Adverse effects is going to be one of the big reasons to consider optimizing our drug of one oral option versus another, for instance. And then the route of administration there. So can we do this IV to PO switch that's going to help with discharge planning potentially? But we got to make sure that we choose the right drug to be able to do that safely. On the duration side of things, again, how long does my patient truly need is really the key question there that has been addressed in some randomized controlled trials. So we're thinking about our patient and we want to transition from IV to oral therapy. The question is, what characteristics are desirable when selecting an oral antimicrobial for treatment of a complicated UTI? Is it high bioavailability, low rates of adverse effects, high urinary elimination, or easy dosing / high adherence rates? Raise your hands for A, B, C, D. I'll say it's all the above. How about that? Sorry, I didn't give that as a response, but you said all the above. That's certainly an appropriate answer. So we'll keep that in the back of our mind as we think about what are appropriate oral step down options for these patients. And so again, flashback to earlier, we're thinking about this transition. What patients can we do it in? They have to be clinically improving, they have to take oral medications. And again, we're choosing a drug that has adequate drug concentrations where it's needed. So these are the typical therapies that we are considering. So fluoroquinolones and sulfamethoxyl trimethoprim, I feel like are largely the bread and butter, or historically have been when it comes to complicated urinary tract infections. But then we have the oral beta lactams that also seem to have a role as well. And so these are the specific ones that are listed in the complicated UTI guideline. And there's a little bit more context as to why they are there. So this first table that I have, this is modified, and this is going to be a great resource that I will refer everyone to go read. We have some authorship members from it, but the ACC IDPRN had put together a essentially pro-con debate of fluoroquinolones and sulfamethoxyl trimethoprim versus highly bioavailable oral beta lactams. So again, that pro-con paper gives a lot of really good perspectives on what evidence supports oral beta lactams versus these alternatives, or why is it maybe not safe to do oral beta lactams. So references there, you can see it with the slides. So again, points here that I want to make, not all the oral beta lactams are created equally when it comes to first bioavailability. So we see things like cephalexin, cefadroxil, or amoxicillin, very good bioavailability. And really, when you compare it to fluoroquinolones and sulfamethoxyl trimethoprim, not that far off. And so I think we've historically always had this in our mind that oral beta lactams are nowhere near the same bioavailability as these other drugs. But that's just not true. And then the other piece of it is thinking about urinary excretion, percent unchanged drug. And so again, some of these oral beta lactams are going to be better than others. And so I'm always going to use this platform. And this is not my main takeaway for the presentation, but Cefdinir stinks. So when we think about it for complicated urinary tract infections, very poor bioavailability. So it's not going to be an optimal agent from that perspective. Coupled with the fact that its urinary elimination is very low, it's just a very problematic drug in this setting. So just say no to Cefdinir. It's what all the cool kids are doing these days. So moving on, we think about the drug characteristics that we want. We also have to think about getting the dose right. And so there's two different papers. The first one on the left was the consensus uncomplicated gram-negative bacteremia document that talked a lot about oral beta-lactam considerations and a lot of the PKPD concerns. On the right are the doses from the IDSA complicated UTI guidelines. And so overall, largely similar between these two. The paper on the left does not include doses for all of them and actually recommends against some of them due to lack of PKPD data. But the key thing here is that these are higher doses than what we might otherwise be thinking about using for these patients. So cephalexin, for instance, for cystitis or skin soft tissue infections, we're typically thinking 500 Q6 or maybe a gram Q8, but a gram Q6 is our recommended dose in this setting. Or amoxicillin, for instance, focusing on Q8 dosing to further optimize our PKPD targets when we're trying to use these oral options. So again, we can think about getting the right drug, but if we don't get the right dose, then it's kind of all for naught. Yeah.
For the time that done with cephalexin and caplex, which is has to take 4 times a day. So I want to know, is there any difference between giving a caplex plus the cefadroxil, just twice a day and it's full.
Yeah, it's a very good question between those two. I'd say a lot of it comes down to lack of experience using cefadroxil. I know my institution personally, we don't use it much, as well as in some of the data that we'll talk about or high level talk about. It's not a commonly studied option, but certainly, I mean, from a PK perspective,
On their action is same for me, the other way around. They come from the with the reflex. I have only citrulloxane to substitute. For the compliance rate and I work for long-term care, I can just go to workshops, work outside, so I cannot do 4 times dose.
right. And I think that's one of the caveats that we'll talk about with oral beta lactams that limits their potential utility. If you have a scenario where a patient can't take it due to inability to adhere to it, or it's just not feasible from administration in a long-term care facility, potentially, that's not going to be the drug for you. And so then we have to consider other alternatives that we can use.
So,
I think it's a tough question because there's a lot of nuance that goes into this. I hesitate to say 100% yes, that you can just make a perfect exchange. Again, there's a lot of limitations to doing that that we'll kind of talk about again. So from making that direct conversion, one of the issues is that we're not testing susceptibilities. I'm getting ahead of myself a little. Why don't I actually just... So the point that I want to make here is this reliance on surrogate susceptibility testing. So this is one of the points that gets brought up as kind of a con for highly bioavailable or oral beta lactams is that we're not testing cephalexin, we're not testing cefpedoxime. We're typically using cefazolin as a surrogate marker. Should we be doing that? I think there's question marks there. But that tends to be what we're most often doing. Now, the counter argument to that is that we're giving patients IV therapy for 3 to 4 days, maybe, before we're making this transition to oral therapy. Should it really matter at that point? Because that's going to change all of our PK/PD modeling, which is really looking at those antibiotics as initial therapy for those infections. And so I'd say in general, I think it would be reasonable to be able to do those pretty interchangeably because there's not a super strong compelling argument one way or another for a different oral cephalosporin within that category, for instance. So otherwise on this slide, so again, making this comparison and thinking about this pro-con debate of fluoroquinolones and Bactrim versus highly bioavailable oral beta lactams. Fluoroquinolones tend to get the nod, I feel like, in this setting just due to longstanding clinical experience. We'll talk about some of the RCT data that they are the most frequently studied therapy, but we know they come with adverse effects in the broader spectrum than we truly need. But then the benefit here is simplified dosing regimens, once or maybe twice daily if you're doing Cipro. On the other side, highly bioavailable oral beta lactams, a lot of mixed clinical data with these. I have one that I'll use as an example on the next slide, but there's a lot of heterogeneity in terms of what drugs are being used, what doses are being used. Is that impacting our outcomes? With these highly bioavailable oral beta lactams, the big concern is higher rates of recurrence potentially. Again, not seen in every study, likely drug and dose dependent. But the benefits to those potentially is these favorable safety and stewardship profiles. So I think there's a lot of interest in using more highly bioavailable oral beta lactams because of the issues with quinolones in particular. So this is one of the studies I was mentioning. So this is a multi-center cohort study looking at gram-negative bloodstream infections from complicated UTI sources. I struggled with putting this one in because I think it really undermines the idea of using highly bioavailable beta lactams, but you can clearly see in this figure that there is a big difference. Now, the caveat is that 67% of the time they were underdosed based on what we would otherwise be recommending. So this is, again, getting at that issue with the current data that we have, that there is this heterogeneity. Patients are underdosed because most of it's retrospective. And so I think as we continue to get more contemporary data of patients that are adequately dosed, we're going to see the oral beta lactams, again, assuming you're picking the right ones, are likely non-inferior. But again, a lot of clinical discussions still to be had within that space. Kind of touched on this already. Again, the heterogeneity is there. My current viewpoint on this, oral beta lactams are an important tool for most patients. I've had pretty good success in non-bacteremic patients. And not to say I've been giving it to bacteremic patients and it's failing. We just haven't gotten there to be routinely using oral beta-lactams in that population. So I don't have much to speak on there. But based on the data that's available at this point, I do think it's a reasonable treatment option to spare quinolones. And so we've a lot of times gone for it in settings of fluoroquinolone resistance, for example. Briefly, because I think I'm going to be pushing up on time here soon. So duration of therapy, the recommendations of the complicated UTI guidelines are for 7 days of therapy. This stems from 10 randomized controlled trials that they reference. Majority of these are evaluating durations of fluoroquinolones. So this is where the fluoroquinolones are also going to get another nod when we think about applying IV to PO switch as well as short duration, is that most of that data is with fluoroquinolones. And so we don't have as much short course data for oral beta-lactams, for instance. There's, again, going to be significant variation in complicated UTI definitions because of how heterogeneous this population is. But there's a couple key exclusions that are noted within these that limit the extrapolation to all patients. And so patients with indwelling catheters were frequently excluded, severe sepsis, immunocompromised, chronic kidney disease, and acute bacterial prostatitis. So when we're talking about short duration, we have to first ask in bacteremia too, and yes, absolutely. And so the first paper, Yaha and colleagues, was uncomplicated gram-negative bacteremia specifically in this RCT. And so they showed with their primary composite endpoint, 7 days was no different than longer durations of therapy. Same thing was observed within the BALANCE trial when they looked at primary or all-cause mortality at 90 days. It was no different. No, this is more than just gram-negative bacteremia. This was everyone except for Staph aureus, essentially. But the key thing here that I said I would mention again is when we look at the primary sources of infection in these patients, it's a lot of time urinary sources. And so really these two disease states go hand in hand when we think about the data and being able to apply the shorter course therapy. So we like the idea of highly bioavailable oral beta-lactams. We like the idea potentially of any oral therapy over IV therapy, but sometimes resistance comes calling and then we're kind of stuck thinking about, oh, shoot, what else can we do? Or we're going to be stuck with OPAT. And so resistance rates, I don't think this is a new idea or new concept, but rates are continuing to rise. This data is a little bit older from the 2019 CDC threat report, but extended spectrum beta-lactamase producing Enterobacterales, they're a problem. They continue to be a problem. The issue is that we would expect an extended spectrum beta-lactamase to hopefully only impact our beta-lactams, but we know that's not the case. And so when we look here, we are seeing all isolates versus those that express this or have this ESBL phenotype. And we look at levofloxacin and sulfamethoxazole trimethoprim resistance rates significantly higher in our ESBL population. So there's a lot of co-resistance there. So when we have an ESBL, not only can we not use our oral beta-lactams potentially, but there's higher rates of quinolone and sulfamethoxazole trimethoprim resistance there as well. So what options do we have? I don't have slides on what we're traditionally doing at this point. So oftentimes we're left then with OPAT, so doing outpatient parenteral antimicrobial therapy, things like ertapenem. I'm not going to go into details on there. But what we are going to do is talk about some of the newer to market urinary tract infection drugs. So I list them all here, oral options up top and then the IV formulations down bottom. We're going to cross out a few of them as they're only indicated for uncomplicated urinary tract infections at this time. And so we'll focus briefly on these 4 drugs just as a little teaser. So we have 2 novel cefepime combinations, so cefepime and metazobactam and cefepime zidibactam. The N-metazobactam, structurally similar to tazobactam, it's going to help against restore activity of cefepime against extended spectrum beta-lactamases. This was documented in the Allium trial, which was its pivotal RCT, where actually demonstrated superiority over pip-tazo. Something I'll mention with a lot of these trials is that the primary outcome and rate of clinical success, or rate of success of the primary outcome, sorry, they look rather low, in my opinion. So what's important to note with all these, it's driven by microbiological eradication rather than clinical cure when it comes to those rates being lower. And so clinical cure in these is really over 90% in pretty much all of these trials. These are effective drugs. It's the eradication piece that we aren't typically doing in clinical practice anyways, but it just kind of deflates the numbers a little bit. On the other side, cefepime-zidibactam. So this is a much broader therapy. So it's dual mechanism, high affinity PDP2 binding by zidibactam. So that's going to give it activity against metallo-beta-lactamase producing organisms, along with beta-lactamase inhibitor properties against amyloid class A and C. And again, it was shown to be superior over meropenem for in the ENHANCE-1 trial. So again, just highlighting when we're thinking about using these in resistant gram-negative infections. So cefepime and metazobactam, no activity against metallo-beta-lactamases, limited activity against serine carbonamases, and really its niche use of the ESDL activity. I have not heard of a lot of uptake of cefepime and metazobactam. I'd be curious by show of hands if anyone has used it. That's what I thought. So not a commonly used drug. Again, it is in our repertoire potentially as a carbapenem-sparing ESBL active drug, but at this time, not a whole lot of uptake. Cefepime-zidibactam, on the other hand, though, does have that broader spectrum of activity. It's going to be active against KPC, still in activity against oxid, but then importantly, it's going to be an option potentially against metallo-beta-lactamase producing organisms. Next is fosfomycin, not our oral formulation that we are traditionally familiar with, but the recently approved IV formulation. So a completely separate mechanism of action from all of our other IV therapies that we're typical, beta-lactam therapies that we're typically thinking of as our backbone. And so again, unique from other antimicrobials because of its mechanism of action, that there's not a lot of direct cross resistance. And so it's approved for complicated UTIs caused by E. coli and pneumo, because it's not going to be hydrolyzed by the same beta-lactamases or carbapenemases. It can continue to have activity against those organisms. And again, shown to have good clinical efficacy in the ZEUS 2 and 3 trial. I don't have it on here. I think there's other thoughts about the use of oral fosfomycin as well. There have been papers on the use of oral fosfomycin for complicated urinary tract infections, where otherwise it's typically only labeled for uncomplicated urinary tract infections. I think you have to be mindful about the dosing that you're doing there as well, but potentially a carbapenem or OPAT sparing option as well to consider. And then really hot off the press, as in I had to go back and fix or add the slide to it, but FDA approved tebipenem on June 17th of this year. So it's the first oral carbapenem for complicated urinary tract infections. And so it was based on the PIVOT-PO trial that compared oral tebipenem every 6 hours versus imipenem. It was stopped early for efficacy of its primary endpoint. So I think this is a really important therapy, especially again, thinking that we're trying to promote this de-escalation from IV therapies to oral and minimize the use of IV antibiotics as best as possible. This is going to be an important drug as a part of that. I do sometimes get a little nervous at the option of the oral carbapenem being more widely available or used. I guess we'll see sulopenem as well as out there. You know, important that we're continuing to think about what patients we're using any of these therapies in, because with great power, we know there's a lot of great responsibilities there. And so use these novel agents when appropriate for the patient, and that the antimicrobial stewardship piece of it remains of the utmost importance. So in summary, empiric and definitive antimicrobial selection for complicated UTI patients should be individualized. So we're following that algorithm set out in these guidelines and really thinking about the key aspects that might dictate what is appropriate clinical therapy for these patients. Considering short course is appropriate for a majority of patients. And so thinking about some of the key exclusions, again, I think we'll continue to see advancements there from like immunocompromised, for instance, that do all of these patients really need 14 days still for their complicated UTI? Probably not, but we're working in that direction still. IV to PO switch should be prioritized again. IV therapy comes with plenty of opportunities for adverse effects, whether that's CLABSIs or other infusion reactions. And so we're trying to promote that switch whenever possible and ensure the right drug and the right dose for the right patient to help facilitate that. And so last piece of this again is the diagnostic and antimicrobial stewardship part of it. And they play a really important role in the management of complicated UTIs. And so limiting how many patients we actually have to treat by getting the diagnosis right, and then optimize antimicrobial therapy from there, and then use our new drugs as appropriate. So with that, I'm going to open it up for some questions, but thank you all for your time. I appreciate you all being here.
One thing, there was no mention of macro weight like nitroflenta and like how in your presentation, I'm surprised to see that.
Yeah, nitrofurantoin doesn't make its way into this presentation as an uncomplicated urinary tract drug. And so, yeah, left it out of there for that purpose, but really focusing again. Yeah, exactly. So not much of a role for the complicated infections that we're seeing here. Same though could be said for fosfomycin, although I added that brief caveat of some literature for potentially complicated infections as well.
The most of the time I get resistance to chloroquine, but sensitive.
Right, and that's one of the challenges too that we sometimes run into from a stewardship perspective is we are seeing all this resistance, and then they see nitrofurantoin, and is it truly an appropriate drug for all of our patients? Well, no, not really. They're not really fitting that bucket. Now, granted, there probably could be expanded use of something like nitrofurantoin with these new definitions of who is truly uncomplicated, while focusing on those patients again with cystitis now as opposed to premenopausal women that are afebrile. All righty. Thank you, everyone.
Thank you everyone for being here for the session, and Caleb again for leading today's talk. I just want to quickly go over how to obtain BCIDP credit for this session. So if you have your programs available, it is on page 3, but I'll also just quickly read through it as well. So to claim BCIDP credit from SIDP, you will need to log into your account at sidp.org. You'll need to make an account if you don't already have one. The steps for creating an account are listed in the program. Once you have your account, you will then access the course at sidp.org/BCIDP. You'll click on the link to claim credit from the Illinois Antimicrobial Stewardship Summit. Click on Login via Personify, use your username and password, and then you'll follow the prompts to claim your BCIDP credit. Any questions, feel free to reach out to us. Thank you.
Thanks for bringing this down.
Good job, dude. Good to see you. How's it going?
Yeah.
Good. Been a little down from leaders. Oh, yes.
Yeah.
Is it going well? I mean, nothing's ever been right. For sure.
I was joking.
Yeah, it's been nice.
So we're learning that. I've enjoyed the stuff for sure. So it's a good thing for my
Right, yeah. Yeah, nice to have them. Yeah,
appreciate it. I'm going to catch up sometime too.
Yeah, sounds good. You run,
So, yeah.
See you.
I was expecting and you can just registration for the response to use them.
Yeah, I mean, I guess, yeah, for like the implementation stuff, most of it's actually posted on our website too, if you want like. That word. Yes, yeah, so feel free to do it all, it's available,
Yeah.
yeah, it's definitely use whatever would be helpful. Where are you at?
Anderson is found by You know Edwards?
I really bad,
No, you're good, you're good.
especially
You go south from Northwestern by
Yeah.
about 4 hours.
okay, oh wow,
Yeah,
so like near the end of the state,
uh,
or
right
not?
by St. Louis,
Okay, oh,
like maybe 15-20 minutes from there.
cool, okay,
Yeah,
cool. Where did you train?
Manchester University in Northeast Indiana.
Oh, okay,
And then I did my residency, PGY1 in Indy at St. Vincent's, and then PGY2 at St. John's. in
Okay.
Springfield.
okay, thanks, awesome, well. Oh, I guess we have break call. Feel free, we are very lucky that we can have everything on our website.
We've definitely used their guys' rating. We love having, you know.
You don't need to recreate the wheel, so we try to post like anything that we.
Yeah.
Wish.
That's fair.
I don't know.
They're probably not like, they're bigger star data probably, but I don't know.